So on to sleep apnea. They may ask us a question about sleep apnea because now we find out that this is a pretty common disease also. So there's two types, but I want you to know one specifically because this is the one that's most important. And I've got it here bold right here. Obstructive sleep apnea is the most important one that you have to know because it makes up about 95% of all sleep apnea cases that we see. Then there's central sleep apnea, right? But the one that is most important, and I'm going to talk to you extensively about, is obstructive sleep apnea. Now, obstructive sleep apnea, basically these patients have some obstruction up here, right, in the upper respiratory system. Their airways seem to be floppy. They seem to be obstructive and floppy. And what nighttime does, what sleep does, it makes them more floppy. It makes them actually kind of collapse together and obstruct the airways even more. That's what happens in sleep time. Sleep is a permissive thing here, where these people have small airways, obstructed airways, floppy airways. They go to sleep, they become more floppier, they collapse more. So the patient that has obstructive sleep apnea goes to sleep, their airways collapse, they close up, right? All of a sudden, you know, they become hypoxemic, right? They wake up to get a breath of fresh air because they're hypoxemic. This vicious cycle happens 500 times a night. That's the definition of obstructive sleep apnea. So during the night, multiple waking up because of a drop in PO2 and a rise in CO2, and this happens 500 times a night, all night long. The next day when these patients wake up, of course, they're sleepy, they're in your office waiting for you, they're sleeping outside your office, you're in a meeting, they're sleeping in the meeting, and so forth. So the cessation of airflow happens at least 10 to 15 times per hour. Like I said, it may happen like 500 times during the night. The O2 saturation increases, the pulmonary pressure increases, so this is a big deal. Because when it happens all night and it happens for years, these people get pulmonary hypertension. They get cor pulmonale. They get hypertension, peripheral hypertension. So this is not a simple disease. They develop, of course, daytime somnolence, and I told you about the hypertension and the cor pulmonale. And now here's they ask this. They give you a patient, and they tell you this patient is kind of obese, right? And he's got daytime somnolence, and this is what he comes to you for. And you check his chem profile, and you find that he has an increased bicarbonate. And they ask you, well, what do you think this patient likely has? And the answer is sleep apnea. And the reason why these patients get an increased bicarbonate is because all through the night, they develop respiratory acidosis, right? A drop in O2, an increase in CO2, so they develop a chronic respiratory acidosis. So what happens when you increase your CO2? Eventually, you compensate some of that by increasing your bicarbonate from your kidneys to minimize the respiratory acidosis. And you could see that on a chemistry profile. You don't even have to do an ABG on these patients. You don't even have to do a pulse ox. You should, but sometimes it's an easier way, an indirect way to find that this patient likely has sleep apnea. So please look for that. The definitive thing is, of course, to get the ABG and the pulse ox. And the gold standard test, you have to do this in order to make a diagnosis of sleep apnea. You can't say somebody's got sleep apnea unless you do this, is to do a sleep study or what is called a polysomnography, where you put the patient in the hospital or in an office room all through the night, they sleep, and then you get all these waves. You measure their muscle retractions, you measure how many times they sleep and wake up, you measure their saturation, and then you diagnose that this patient has cessation of airflow at least 10 to 15 times per hour, and they wake up with their muscle retraction, trying to breathe air in after this happens and so forth. Then you've diagnosed obstructive sleep apnea. You have to do that. So the answer is, how do we diagnose sleep apnea? We have to do a polysomnography test, And what do we have to show? Cessation of airflow 10 to 15 times, and at the same time, retraction of muscles. Because remember, this patient, once they develop hypoxemia, they get muscle retractions and start to wake up. That's what you show in obstructive sleep apnea. What do we do with these people? Well, first of all, we tell them to lose weight, and then we, at the same time, we give them this machine called a CPAP, a nasal CPAP. What a nasal CPAP machine does, it basically, it's not just oxygen. People think it's, give them home oxygen. No, a CPAP, what it does is it gives the patient oxygen under pressure. What it really does is it puts pressure on the oxygen, so it splints the airways by giving oxygen under pressure. So very important, a CPAP is not just oxygen, it's oxygen under pressure, splinting the airways, keeping them open so the patient breathes during the night. If you don't do that, the patient eventually develops right-sided heart failure. This is a devastating disease. So please look into that. The patient has to get CPAP machine. They don't like it in the beginning because they have to fit the mask and stuff like that, and who wants to sleep with a mask? But then after they've used it a couple of weeks, they feel so much better. They feel so much rejuvenated because now they're sleeping at night. They feel totally different persons. We could also do surgery here, but we reserve that for last. Uvuloplasty, you only reserve that for last after you've done weight loss, CPAP, and all that stuff, and it hasn't worked. Then you decide to do surgery, only when all this other stuff doesn't work. So please, the one that they will likely ask us is about the weight loss and the CPAP, not the surgery. Central sleep apnea is different. Central sleep apnea means there's something centrally wrong with those receptors. Instead of everybody, breathing, 12 to 14 times a minute, these people, especially at night, they drop down low and they breathe 5, 6 per minute. This is a central drive. So you could see that on the polysomnography, because you don't see any muscle retractions when the patient develops hypoxemia. And then all of a sudden the trigger goes on, to breathe now, and they start breathing again. These patients have daytime somnolence also. Central sleep apnea is very rare. So even if you don't know which one it is, obstructive sleep apnea is the right one, because most of the time, I told you 95% of the cases that we see is obstructive sleep apnea. But central sleep apnea, there's a central process that tells these people to breathe slower, or don't breathe enough. It's a better terminology. Don't breathe as quick as normal people, and they develop chronic hypoxemia, hypercapnia, and they develop cor pulmonale. These patients, CPAP doesn't really help a lot. It doesn't help as much as obstructive sleep apnea. What they do in these patients is they give them acetazolamide. Acetazolamide, the diuretic, is the treatment of central sleep apnea. It makes them breathe faster this way. Sometimes giving progesterone works too. It makes them breathe faster this way. So central sleep apnea, acetazolamide, progesterone. Obstructive sleep apnea, weight loss, CPAP. That's the way we go. And that's the end of our sleep apnea chapter.